Ma'am, we are starting session, ma'am. So very good evening, doctors. I am Dr. Stalin on behalf of Shield Healthcare, welcoming you all for the today's webinar. The topic for today's webinar is Diagnostic Laparoscopy in Treating Infertility. I welcome all the delegates. I request them to post their queries in the chat box so that we can have a short Q&A session at the end of this presentation. And now it's time to introduce our invited speaker for the day, Dr. Swapna ma'am. Madam has done her MBBS DGO and Madam has done her MBBS DGO from Kakatiya Medical College, Warangal. Madam is currently the Senior Obstetrician and Gynecologist, Infertility Specialist, and the Director of Aradhya Hospital, Kukatpalli, Hyderabad. Madam has also worked as a Senior Physician in Bhavani Infertility Clinic and Kukatpalli. So with this short introduction, I welcome you, ma'am. I'm handing the session to you for further proceedings, ma'am. Welcome, ma'am.
Thank you. First of all, I'd like to thank Shield Healthcare for giving me this opportunity to share my views. And thank you, my dear colleagues, for giving your valuable time to see my presentation. Thank you, everyone. I'm Dr. Swapna, Director of Aradhya Hospital. Today I'm going to speak about diagnostic laparoscopy in treating infertility. As you all know, infertility is being defined as a woman or a couple who is unable to conceive even after 1 year of unprotected intercourse. But as we know, the fertility decreases with age in a woman. For women more than 35 years, if they do not conceive within 6 months of unprotected intercourse, then we treat her with infertility treatment. Okay. Coming to infertility rate in India, according to Indian Society of Assisted Reproduction, it affects about 10 to 15% of Indian population, whereas it is more of approximately 1 in every 6th couple is being affected with infertility because of the lifestyle, the stress conditions, and the pollution. All those factors do impact the rate of conception. As per WHO, it is seen that about 3.9 to 16.8% women come under primary infertility. Now coming to the major factors in female infertility. The first and foremost being the age of the woman. The other factors like diabetes, hypertension, obesity, endometriosis, hormonal imbalance, PCOD, any pelvic infections. These are all the factors which lead to infertility in a woman. And the main factors affecting the management of infertility being first and foremost age of both the partners, the duration of infertility, any prior treatment failure, and the cause of the infertility. Let me discuss about a few causes of female infertility. The main being ovarian, tubal, uterine causes, cervical causes, vaginal and peritoneal causes, and unexplained infertility. In recent times, we are getting that almost 30 to 40% of the women come under unexplained infertility, which we are trying to evaluate. Okay. Let us come to laparoscopy. What is laparoscopy? Laparoscopy is a surgical procedure in which a fiber optic instrument is inserted through the abdominal wall to view all the organs in the abdomen and to permit a small scale surgery with the help of pneumoperitoneum. It is also called as band-aid surgery or minimal invasive surgery or keyhole surgery, and the surgery can be done with a very small incision of about 5 mm to 10 mm. Coming to the history of the laparoscopic surgery, at about 1910, Dr. Hans Christian Jacobius, a Swedish surgeon, first described laparoscope, where he used air pneumoperitoneum and a cystoscope to evaluate the peritoneal cavity of TB patients with ascites. After that, at about 1961, Dr. Palmer, he described first laparoscopic retrieval of oocytes. And he described a point called Palmer's point. It's about 3 centimeters below the last rib in the left midclavicular line, where we use it as a laparoscopic entry. Many of the surgeons say this to be a virgin area of the abdomen, because even after a woman having done n number of laparotomies or laparoscopies, this area is a place where we just don't find any sort of adhesion. If prior to the surgery, if at all we find any sort of in the history, if we find any sort of laparoscopies or laparotomies done, we usually prefer this point for entry into the abdomen. In addition of monitoring, this point is also used for monitoring of intra-abdominal pressure. And also, Dr. Palmer, he was pioneered in intra-abdominal coagulation of bleeding sites, puncture of cysts, and lysis of pelvic adhesions. Okay. As of laparoscopic surgery, as you all gynecologists know, that laparoscopy is now used for hysterectomies, incontinence procedures, and even for the diagnosis and treatment of gynecological malignancies. These days, laparoscopy has invaded all the branches, and any surgery can be done laparoscopically, how much ever big it is, except cesarean section. Coming to diagnostic histolab, it is one of the commonest procedure performed for fertility enhancement, and almost 40% of the patients undergo diagnostic histolab during fertility workup. And the use of laparoscopy in ART, with recent improvement in ART techniques, the diagnostic histolab has come down, but as such, we don't routinely use diagnostic histolab for all cases. But if at all need arises, then we do first laparoscopy and then go for artificial reproductive techniques. Okay. First and foremost, for PCOD cases, the first line of treatment is the diet, lifestyle modifications, insulin sensitizers. It has a major role. Then followed by controlled ovulation induction with or without IUI. That is still the first line of management. Laparoscopy, it is considered in cases with failed ovulation induction with IUI. And laparoscopic ovarian drilling, we follow a norm called rule of 4, where almost per ovary we puncture 4 sites with a 4-watt energy for 4 seconds. That is how we do laparoscopic drilling for women with resistant PCOS. According to Cochrane review, laparoscopic ovarian drilling it is as effective as gonadotropins. And it is effective in women who are resistant to gonadotropins with clomiphene-resistant PCOS. The advantage of laparoscopic ovarian drilling over gonadotropins with clomiphene resistance is there is a reduction in multiple pregnancy rate when compared to gonadotropins. Okay, now coming to endometriosis, laparoscopy in endometriosis. Research has a conflicting result for mild endometriosis, but for moderate and severe endometriosis, as per ASRM Committee Opinion 2012, there is definitely improved chance of pregnancy has been seen. But the optimal laparoscopic treatment requires not only surgical skill but also a knowledge of pelvic anatomy and a good understanding of endometriosis and its progression. Large endometriomas are definitely removed surgically prior to IVF so that the chances of IVF and live birth rate increases. But for very severe endometriosis, it is not beneficial. Rather, there is a chance of reducing the ovarian reserve. So we directly ask a patient to go for ARP. Meta-analysis demonstrate an advantage of laparoscopic surgery in terms of clinical pregnancy and live birth rate. Laparoscopy in treatment of subfertility related to mild to moderate endometriosis, it does improve future fertility, according to Cochrane Review 2009. Coming to ovarian cyst and laparoscopy, surgery is only indicated in larger cysts with associated potential complications. But when the cysts are small, less than 3 centimeters, it is better we go for a conservative management because there is every chance of decreased ovarian reserve with laparoscopy. But for benign ovarian tumors, laparoscopy is the best modality because it is associated with reduced post-op pain, complications, and reduced post-op adhesions. Coming to the fibroid uterus, according to current opinion of Obstetrics Gynecology 2013, fertility outcome was decreased. But recent studies have shown that laparoscopic myomectomy is considered before ART to decrease the effects like spontaneous miscarriage and all prior to the surgery. And it is also feasible technique, safe for patients waiting for conception, and has proven its interest in the case of infertility. Coming to proximal tubal block, almost 55 patients have conceived with successful hysteroscopic proximal cannulation. And the mean time for pregnancy outcome after cannulation was about 10 to 18 months. Laparoscopic hysteroscopic cannulation for proximal obstruction is a procedure. It's with minimal morbidity and a successful recanalization rate is noted. And it is also considered as an alternative for IVF. Successful tubal cannulation led to significant improvement in pregnancy rate in women, and laparoscopic guided hysteroscopic cannulation is still a viable alternative for IVF. Coming to Hydrosalpinx with laparoscopy, in laparoscopy for Hydrosalpinx, we consider two options, either salpingectomy or tubal occlusion. But studies have shown that salpingectomy prior to IVF, it does increases the clinical and the ongoing pregnancy rate. But with tubal occlusion, there is only increased clinical pregnancy rate, but not so much ongoing pregnancy rate. Next, coming to laparoscopy in ectopic pregnancy, almost 79% of the ampullary tubal ectopic pregnancies were managed using laparoscopic linear salpingostomy, and 62% of the women conceived after salpingostomy, and live birth rate was about 38%. Meta-analysis show that laparoscopic surgery is the most cost-effective treatment for tubal ectopic. Systemic methotrexate and laparoscopic salpingostomy was successful in treating majority of the cases with there are no significant difference between the treatment in both of them. Coming to tubal reversal or tubectomy recanalization, it is an alternative to microsurgery, laparoscopy. Laparoscopic tubal anastomosis, it's a highly successful procedure, less invasive, and it is to be considered in women who desire for laparoscopic recanalization. And what are the cases to be suitable? All cases with prior laparoscopic sterilization were suitable, whereas women who have undergone fimbriectomy were unsuitable for laparoscopic recanalization. And compared to hemorrhoids and laparoscopic tubal ligation, the reversal percent after hemorrhoids technique was about 40%, whereas after laparoscopic tubal ligation, almost 85.7% conceived. So laparoscopically sterilized patients have a better chances of conception following reversal than those who were sterilized by hemorrhoids method. And few things like with post reversal tubal length of more than 4 centimeter and isthmus ampullary anastomosis, there is almost 50% success rate is seen. Coming to unexplained infertility in laparoscopy. Laparoscopy may be omitted in women with normal HSG. Prior studies are showing that, but recent updates have shown that almost 80% of the patients after normal HSG after doing the hysteroscopic lab, there was definitely a chances of increased pregnancy rate and increased live birth rate after hysteroscopy. So histolab is an effective diagnostic and corrective tool for pathologies like peritoneal endometriosis, adnexal adhesions, and subsubtate uterus. Hysteroscopy prior to ARP. Few studies have shown that hysteroscopy has a role and it has a higher clinical pregnancy rate in the subsequent IVF cycle in a hysteroscopy group. Hysteroscopy in asymptomatic women prior to first IVF cycle has found to be associated with improved chances of pregnancy and live birth rate. But trials is needed for more research. Okay, coming to summary, lab ovarian breeding results at least in equal pregnancy rate as gonadotropin treatment. The added benefit being less of multiple pregnancy rate and laparoscopic treatment for endometriosis, minimal endometriosis shows conflicting results, whereas for mild to moderate endometriosis, it does improve the fertility. Excision of the endometriotic wall, it does increase the spontaneous conception rate. Myomectomy for submucosal fibroid, it does result in a higher pregnancy rate. Removal of intramural or submucosal fibroid, it shows a beneficial trend. For benign ovarian tumors, definitely there is improved fertility outcome and it is cost effective. For proximal tubal block, laparoscopic guided hysteroscopic cannulation is still a better alternative prior to IVF. And laparoscopy is cost effective for tubulectomic pregnancy. Laparoscopic recanalization is a highly successful procedure, and laparoscopically sterilized patients have a better chances of conception. Removal of polyp prior to IUI does increase the pregnancy rate. Laparoscopic tubal surgery for Hydrosalpinx prior to IVF does increase the pregnancy rate of about 95%. And hysteroscopy in patients prior to IVF does increase the pregnancy rate even though when there is any absence of pathology. Hysterolab is an effective diagnostic and corrective tool in case of unexplained infertility. Diagnostic hysterolab may be of a considerable value before IUI. Further studies are need to be done. And hysteroscopy prior to IVF does improve chance of pregnancy. Let me conclude the session by saying that laparoscopy is still remains and important diagnostic and therapeutic tool in the management of fertile women. Optimal and prudent use of this minimal invasive technique is they have a costly treatment like IVF, but its use should be strictly restricted. Although the limited evidence indicates a positive role for surgical reproductive interventions, we should use it clinical practice of reproductive surgery since more research is needed as per corporate review 2001. I conclude my session saying that laparoscopy does have its own benefits, and nowadays laparoscopy is definitely improved, has definitely shown an improved chances of fertility in women who are targeted for conception. Thank you.
Thank you, ma'am. Thank you very much for that another wonderful presentation, ma'am. Ma'am, let me wait for 1 or 2 minutes for the participants to post their queries, ma'am. If there is any queries, then I'll read out for you, ma'am. Our dear participants, if you have any queries, you can just share in the chat box so that I can raise the question to the speaker today. Ma'am, I have a question like, ma'am, how long the couple has to wait after this laparoscopic surgery for when they're looking for pregnancy, ma'am? How long they should wait, ma'am?
If at all the woman is of a lesser age group, we can just wait for 3 months and not more than that. Even after 3 months of laparoscopy, if she doesn't conceive naturally, we better go for IUI or IVF, that sort of thing. And if her age is more than 35 years, 1 or 2 cycles of natural course of, if at all she doesn't conceive within that, we better ask her to go for IVF.
Okay, ma'am. Ma'am, is there any complications related to this laparoscopic surgery, ma'am?
As of such, the only cause where the only thing which we are worried is sometimes for ovarian cysts and all, after removal we find an decreased ovarian reserve. As of that thing, nothing more than that. And laparoscopy has definitely more conception chances when compared to laparotomy or conservative management.
Okay, ma'am. Thank you, ma'am. Ma'am, fine, ma'am. There is no questions in the chat box, ma'am. So if there is any questions forwarded to us, we will be forwarding the questions to you, ma'am, through mail or through WhatsApp. You can just address those queries, ma'am.
Yes, thank you.
So participants, if you have no queries, then we can end the webinar for today.
Yeah, thank you so much, ma'am, for a wonderful session today. So we expect you to give more and more webinars coming forward. We look forward to that.
Thank you for giving me this opportunity, and I'm looking forward for more webinars too. It's a what to say? It's a almost by learning. We also by teaching we also learn, and thanks for giving me this opportunity.
Okay, thank you, ma'am. Thank you so much.
Thank you, ma'am. Thank
So
you for.
we are closing the session, ma'am.
Yeah, ma'am.
Yeah. Thank you. Thank you.